Good morning, or I guess we're just into the afternoon. I'm going to take a slightly different approach that is not refuting anything you've heard this morning, but just trying to put it in perspective. And really focus on, as we talk about all this exciting science that is truly changing our capabilities and potentials, what can we offer our patients today? What's a realistic thing for them to be expecting? And where are we at risk for overhyping and overselling what we've accomplished? It's a complicated area, somewhat delicate. So when we talk about precision medicine, next generation sequencing, and what patients are looking for today, I want to make clear what we're not talking about. We're not debating that which is current standard practice. And some personalization of medicine is already clearly standard practice. So RAS, RAF, MSI for colon cancer, EGFR, ALK, ROS, BRAF for non-small cell lung cancer, ER/PR, HER2 status for breast cancer, and of course HER2 status for esophagogastric cancer. These are part of standard practice today. So they're incorporated into precision medicine, and it's simply moving the bar. Before, it was more precise to separate esophagus and gastric from pancreas and colon. We got more precise as we started looking at tumors of origin. This is just an extension of that. So what we're really talking about, what patients are looking for, what advertising implies, is the use of genomic analysis beyond what is currently accepted practice in order to identify previously unavailable treatment options for a patient, either on a research protocol in those cases where that's available, or what people are really hoping for is finding out that some standard therapy is available that otherwise wouldn't have been. So we have to step back and ask what and who defines what drugs are standard practice in the United States. And basically, FDA approval for a specific tumor type, stage, and clinical scenario, or a compendium listing, usually in the NCCN because it's the broadest and most up-to-date oncologic compendium, for a specific tumor type, stage, and clinical scenario, define standard. And the question is, why? The answer is because that's what Medicare will pay for. Simple as that. You don't have to like it, but it is the reality. If Medicare will pay for it, commercial insurance will pay for it. If Medicare won't pay for it, commercial insurance feels entitled not to and often won't. That doesn't mean we can't call them, debate with them, argue, and sometimes win. But we can't expect it and we can't define it as standard practice. So what happens when we start asking the Center for Medicare and Medicaid Services about NGS? They come up with their national coverage decision. They took 1.5 years to do it, and they came up with this, and don't worry that this is too small to read and too busy a slide because it doesn't say that much. So actually what I did is I weeded this down a little bit. I didn't add a single word. I just removed some, and it didn't change the meaning. So I removed some more words, and it didn't change the meaning. And then I cleaned it up a little bit, and this is really what all that gobbledygook said. It says NGS assay is covered nationally when all of the following are met. Now, this is covered nationally by a Medicare national coverage decision. The patient has recurrent stages 3 or 4 cancer, which I think is fascinating because I have a real hard time figuring out, at least in GI, how I'm going to use stage 3 in information, but thank you, it's generous. Not previously tested with the same NGS assay. That's the wording. Does that mean if it was previously tested with another NGS assay, they'll pay for a different one? Not clear. And the NGS assay must have an FDA approval or clearance as a companion diagnostic. I'll explain that in a moment. An FDA approved or cleared indication for use in that patient's cancer, and a report template to specify treatment options. So if that clarifies it for you, you're doing better than me. But that's more or less what the rules say. And Foundation Medicine, of course, moved in on that because this is their market, this is their business, and put out on their website in March their interpretation of that the final NCD gives coverage for all metastatic, recurrent, relapsed, or stage 3 disease, coverage across all solid tumors, and this is one, it's incredible to what degree people who are in the policy world focused on this. Repeat testing is covered when a new primary cancer is made. Big deal. Okay, I got it. You got colon cancer, you got a new lung cancer, we'll let you test the lung cancer. Thank you very much. That is such a rare phenomenon, it doesn't really address the question that people are often asking, which is, how often can I do this? Does it change? Is it covered in multiple scenarios? And apparently the answer would be no. So a couple of observations I would make about this. The requirement for a companion diagnostic seems to be really kind of weird for an NGS assay. It doesn't appear consistent with the concept of a particular diagnostic, and it misses the point of an NGS assay, and it naturally assumes that the older technology is better, which is not necessarily true. So here an example of what we mean by a companion diagnostic. It's a diagnostic that helps you find these particular genes in these particular tumors because we need it to decide what to do for a particular type of cancer. But it doesn't make any sense if what you're doing is looking for new inclusionary markers that would open a new therapeutic option for the patient. Now, this is the one that I think changed the game for us. This is the one that Luis and his team published back in 2015, and he mentioned briefly before in his talk, that basically Pembro is approved for any tumor that has high microsatellite. I would have therefore interpreted that that makes every NGS assay that can tell you whether or not a tumor is MSI a companion diagnostic. It's interesting, the regulatory people tell me that's wishful but not true. So it just shows how opaque all of this is. These are the data Luis just showed you, showing that basically we see this across the panoply of tumor types. From the press release that came out with it, this language I thought was interesting. These tests are used, a companion diagnostic, to identify patients with certain genetic mutations that may benefit from FDA-approved treatments. So that's that companion diagnostic concept that I just showed you. And then this interesting statement. Additionally, when a known cancer mutation cannot be matched to a treatment, then results from the diagnostic lab using NGS can help determine the patient's candidacy for cancer clinical trials. Well, that's nice. That helps us here, perhaps, because we have clinical trials. However, a couple of interesting questions I couldn't get answered. I'm still trying, so I made this little test for CMS. They haven't taken it yet. Can it be used, can an NGS assay be used for any tumor type? There really isn't anything clear that says that, because the wording says it has to be a tumor type for which there is a specific companion diagnostic. If CMS has paid for one approved NGS assay, will they pay for the same patient to have an analysis performed by a different approved assay? If I've used MSK Impact and the patient doesn't like the answers and wants to go get Foundation Medicine or Caris, will that be covered? It's not clear. I can't see a logical reason why it ought to be, but the wording doesn't clarify. Can an approved NGS assay be used solely to look for eligibility for clinical trials of targeted agents? That's what we want to do here, and the wording doesn't make it clear. We cannot tell you whether or not Medicare would regard doing that as standard practice or insurance fraud. And by the way, understand that that's the two choices. Because if you bill Medicare for something they think you shouldn't have done, they don't consider that an honest mistake. That's called Medicare fraud. And the penalty for Medicare fraud is treble damages plus interest and penalties on top. So it's not something you want to do. So these questions matter, and we can't get the answer. One thing that's clear, it doesn't cover serial testing with the same assay. So whereas Luis just showed you, for example, that serial liquid biopsies might identify early failure, firstly, I would argue that while that is scientifically important and something that I hope we build on to learn how to use therapeutically, we don't know how to use that therapeutically now. But clearly, that's not covered in the current assay. And if you do happen to get lucky and identify a mutation for which there are drugs available, they are not covered. So that creates a whole lot of problem because they tend to be a little pricey. So what's preventing us from using universal NGS across the spectrum? The cost of the test, the success as a predictive marker, and the cost of the drugs that we'd recommend. I won't take you through all the wording of this, but just to point out, because people often say, well, it's not our business as doctors to worry about the cost of these things. I would argue that it has always been our business. And this is from Annals of Internal Medicine in 2002, showing basically the physician charter put forward by the American Board of Internal Medicine Foundation and American College of Physicians, suggesting that, in fact, scrupulous avoidance of superfluous tests and procedures and wise and cost-effective management of limited clinical resources have always been our responsibility. Some general thoughts on the cost and value of these things. When we talk about value, when we talk about cost, it's important to remember that they move in opposite directions. So for anything, if we say, well, it's not that valuable, if we cut the cost in half, we double the value. And if we double the cost, we have the value. And so whereas we say, well, cost shouldn't be our issue, if we're more comfortable that using high-value care should be our issue, we have to understand what these things cost to understand what the value is. And this is important because we've got to manage our expectations as we offer these technologies, both to ourselves and to our patients. This is the way the outside world, the non-research world, is starting to view what's happening in cancer. This is an editorial from the Wall Street Journal earlier this year. In the war on cancer, truth becomes a casualty. That's problematic. We're being viewed as an industry that appeals to emotion, misleading ads and misleading promotions, and we have to be very careful to try to rein that in. Here's an example of this. This is a letter that I received just about a year ago, unsolicited. I'd never heard of the person. Dear Dr. Saltz, I saw a brief TV program about a clinical trial called Precision Oncology that you are currently practicing, where a patient who had tumors all over the body had taken 2 pills every day for a week, and the tumors disappeared. We are desperately seeking other medical help for my father. It's kind of tragic. It's really, really upsetting. This is what the world thinks we're offering out there. So what have the clinical trials shown? What do we have? Well, this is the Shiva trial that was published in Lancet Oncology in 2015. And here, in a randomized fashion, patients with the molecular profiling done were given a targeted agent or physician's choice, and you can see that these curves don't separate. There was no indication of benefit in this trial to the idea of a molecularly targeted therapy. The MOSCATO trial looked at 1,000 patients, and in each, and here I give you the breakdown on what happened. 91% successfully got a biopsy. That's pretty good. 81% obtained the molecular analysis. 39% had what was defined as an actionable mutation. Now that's a very broad term. Just because it's actionable doesn't mean we know what kind of action to take. And of that, 19% actually received a match-targeted therapy, and 22 achieved a major objective response. So if we start of the 1,035 people that enrolled in this clinical trial with the hope for benefit, 2% achieved a response. And of the 199 who did receive the match therapy, 11% received a response. Now, even 11%, I would argue, is a whole lot smaller than our customers are expecting from us. But ultimately, it's that number at the top of the slide that is really the appropriate denominator when we assess that. Now, is 2% better than 0? Yeah. Is it what people think we're offering out there? Probably not. You've heard a lot about the NCI match test. These are the most recent data. They're a little out of date, but they're the most recent that have been published, and this was as of March of 2017. At that time, 4,700 patients had tumor samples, 3,500 received their test, 720 had an abnormality matching an available treatment, and 495, or 10%, had enrolled in a treatment. So here again, only 1 in 10 who is coming to the match trial is actually enrolling in a therapy. And that's not the end point. The end point is, did we help them? The answer is not as good as we would hope. Here are 3 trials that were presented at ASCO this year that were all arms of the match trial, looking at Tacalysib in a PIK3CA mutated population, AZD4547 in FGR mutated or fusions, and TD1 in HER2. And here are the number of patients enrolled, here are the number of patients with responses, and here are those percentages. Remember, this is the molecularly selected subset on a clinical trial. This is as good as it gets. This is not the real world where we expect some drop-off. It's sobering, and it's not what we were hoping for not what we're expecting, but it's what the data show us. Here are data from our institution. Maeve Lowry published this last year, looking at our effect on pancreatic cancer. 336 patients that underwent impact. Of those, 18 patients had what we regarded as a 2B level mutation. 3 of those were KRAS wild type. Remember that when you have a mutated KRAS, it tends to overdrive over the majority of so-called actionable mutations, so that even if you find what seems to be a target in a KRAS mutated patient, it's not going to be clinically relevant. 3 patients out of 336 at our institution where we live and breathe this stuff actually received a matched therapy. That's not the percentages the world think is out there from quick, go get your tumor genotyped. Here's our colon data that Roni Yeager published in Cancer Cell earlier this year. 1,100 patients, 5% BRAF, 4% HER2 amplified. A significant percentage of those, by the way, the HER2 amplified were RAS mutated, where again the HER2 amplification does not seem to be clinically relevant. And then 1% TRAC fusion, 16% PIK3CA, half of the patients with a RAS mutation. So a very limited opportunity for advanced use of targeted agents. Here's one of the problems if we find them. We've gotten excited about the fact that BRAF mutations in colon cancer can benefit not from a single BRAF inhibitor, but from a 3-drug combination. But by the time we're giving dabrafenib, trametinib, and panitumumab for 4 weeks for one person, we got a drug cost of $37,000 and an annual cost approaching $500,000 per year. That is before you get into the cost of the genetic testing to find it. And the question, again, that I think the answer is rhetorical, is that sustainable? Is that realistic? Here's another example of where we were hoping for a lot more. This is one of David Hyman's publications from our drug development group here. AKT inhibition in AKT-mutated tumors. 58 solid tumors. We got 9 confirmed response. 3 unconfirmed, which means that they didn't last long enough for a confirmation. And the median progression-free survival was around half a year, okay? In terms of patients with control of tumor greater than a year, it was 7%. 7% control, AKT mutations with AKT inhibitors. That's far more limited than patients are hoping for. Does it validate the scientific hypothesis that going after a mutation with a TKI will have some clinical relevance? Yes. Is it at the level that our hopes, our expectations, and our advertising are suggesting? I would say no. And here's one last example. This is looking at a basket trial of Neratinib in patients with either HER2 or HER3 mutations. As expected in breast, where the drug is licensed, we saw reasonable activity at 32%. But in, again, the molecularly selected subpopulation in lung, bladder, colon, virtually nothing, and HER3 mutations, nothing. Again, not what we hoped for. So what's good enough? What's good enough to be worth it? Targetable finding in half, in a tenth, in 100th, in 1 in 5,000. This has become relevant because if we're looking for a mutation in 1 in 5,000, we have to pay to screen 5,000 people to find one that we might be able to help. And what if that one we find is going to be helped maybe 1 of 10 times? Now we're talking 1 in 50,000 screens in order to help a patient. Is that practical? Where do we draw the line? Looking at the percentages, what should be our thought pattern on that? Is there a floor? Can we as a society reach a number that we say, well, if it's below that, we'll stop? When I started at Memorial Sloan Kettering, the standard phase 2 study was 14 patients in the first arm. And the statistical hypothesis was if 0 of 14 stop because you can say with 95% confidence that there's less than 20% single agent activity. That's, of course, gone by the boards because almost no drug that we've developed in the last 25 years can meet that standard. Maybe that standard was too high, but there's got to be a floor somewhere. What's good enough for clinical benefit? Again, response or disease control at 4 months Is 4 months a target? I just threw it out there for a thought. Getting to that second scan and beyond, what percentage would we look for? So to conclude, basically, I'm not saying that we don't need to continue what we're doing. I'm saying we absolutely need to continue what we're doing. We have to stop pretending that we're there. We have to be careful in separating that which is a work in progress from that which we can regard as standard practice that we can and should be advertising to our patients and offering them. As we work to maximize benefit from the tumor profiling, we have to keep reasonable perspective on what can be expected and help our patients to maintain reasonable expectations as well. With NGS, as with so many aspects of cancer care, we must strive to maintain a balance between optimism and realism, without which it is easy for our patients and their families to build up expectations which far exceed what we can realistically hope to deliver. Thank you very much. So the question was, would earlier stage testing have better therapeutic activity? I'm not clear if you're asking, should we be using this on earlier stage cancer, or should we be using this on advanced cancers but with an earlier test? I think what we're finding is the majority of the so far clinically relevant mutations seem to be relatively early on, and when they're acquired late, it's perhaps a subclone and not as clinically relevant. So it's quite common that the tissue that we have available for testing is a primary, and that turns out to be very clinically relevant for our therapeutic decisions in treating the metastases. As to whether using a molecular profile and a targeted therapy to reduce so-called recurrence in the adjuvant setting to increase the cure rate early would be useful, that's an important hypothesis. In general, what we're looking for is robust activity in the metastatic setting first, and then move that into the adjuvant setting to see if we can improve the cure rate. I think we have to get to that robust setting first before we ask that question. And it would be an important line of investigation, not yet a standard treatment. Okay. All right, thank you very much.
Great.